over time, when you started seeing people as having worth and needing some kind of dignity and understanding and compassion, and actually Christians had a big part of this. So as we come into what we would think of more modern for us, then you see a shifts in how we treated people.
Welcome, everyone, to Breaking Bread, the podcast brought to you by Apostolic Christian Counseling and Family Services. Excellent to have everybody along. This May, as Mays have been, is Mental Health Awareness Month, and I've got Ted Witzig and Ron Messner to talk about mental health. Welcome, both of you.
Hi, Matt.
Yeah, thanks for having us.
1949, evidently, is when May was declared Mental Health Month. But I think it is telling because there's usually an impetus behind a month being declared some sort of awareness. And that really posits our conversation, I think, nicely. Back in 1949, there's probably a story there, right? But even beyond that, to see mental health, certainly ACCFS has a lot at stake with mental health and being thoughtful about mental health. But I thought how appropriate it would be, and I think beneficial for our listeners to hear somewhat of a story. I think we're going to hear some stories here today. I'm hoping so.
Sure.
Hear some stories today, but also help us connect some dots to mental health becoming on the radar, becoming understood in terms of general welfare and general knowledge. It hasn't always been that way.
Right.
Is that fair to say?
Sure.
And I think there's a lot to be learned. Well, there's always something to be learned by history. And so I'd like to push into some of that history, Ron and Ted, both of you, to help push into that history. And I'm going to go ahead and recognize and call out here at the beginning that some of this history is very Central Illinois based. And I know our listeners expand beyond that border, but that's the history that we're familiar. That's the air that you two breathe. But yet it probably isn't too far off the mark of a larger national scene.
Sure.
Am I right about that?
Yeah, the original response from Illinois very much fit what was going on nationally, the things that were occurring, the questions being raised.
Yeah.
They fit a national context.
So I would like, Ron, and I've heard you share on this topic of mental health and awareness, but what do you think was the impetus behind the mental health profession saying, you know what, we need to raise awareness? And this happened back before the 50s.
So some of this is speculation. I'll share it because I think it matches the time frames. Prior to 1900, I'm pretty sure up until that time that all mental health was seen as a moral and character issue. And so it was addressed, and if we look at Scripture, all the references that are there, we really don't know what was an evil spirit, but there was no other context. If somebody was mad, that was the only explanation. And I'm pretty sure that probably continued until the late 1800s and early 1900s, when people began to be seen as a person, but they didn't understand what was going on, but realized it was something happening to a person. And I think that the treatment reflected both that and the fact they didn't know what to do. That there was, I was just rereading again this morning, somebody who was interested in the movement going and visiting somebody.
When you say interested in the movement, what are you speaking of?
Knowing how people were being treated up till that point and wonder what could be done. And he described a person visiting somebody who lived in basically a log pen outdoors. He had no feet because they had frozen off, and they would open the pen and basically hose it out once a week at least, except in the winter when they didn't do that. And there was nothing to do with this person who would have been probably said to be mad. Then there's probably the word they would have used. They couldn't be kept in the house. They couldn't be around people. They were not safe. So the only possible way to manage was just to build a pen and lock him in it.
So Ron, you're tipping your hat at a movement that was coming to see how people were being treated, and there was a movement here to think differently about the plight of people.
That's right.
Is that right?
The farther you go back, everything was kind of lumped together and treated together. And so in the old time insane asylums, even if you go back into England and things like that, you would have had people that had, schizophrenia and bipolar disorder, but you would have also had people with other kind of disabilities. And you would have people with, seizure disorders and all different kind of things that today we would go, oh, no, what you do is this, or oh, no, what you do is that. And because they had their only context was either moral or like a moral failure or a demonic thing or whatever, then that drove the treatments. Over time, when you started seeing people as having worth, okay, and needing some kind of dignity and understanding and compassion, and actually Christians had a big part of this, then you also started seeing things shift as well. And at the same time, understanding of human anatomy, bodies, and just even the social aspect of that community makes a difference to people. Being a part of something makes a difference to people. So as we come into what we would think of more modern for us, then you see a shifts in how we treated people.
It seems to come also on the raised awareness of the complexity of life.
Yeah.
I mean, you take today, they're starting to break, the atom down into its parts, right? We understand at the atomic level the complexity, right, that no other generation has understood. Sure. And that's happened on many different fronts. And this idea of mental health would be one of those fronts where complexity is now being seen, whereas in the past, it was painted with a pretty broad brush.
Mm-hmm. I think one of the things, Matt, that you'd notice if you go back and look at historically what happened, I'm going to say interventions because they weren't treatments, but the interventions were based on what was necessary to manage the person's behavior. So there is we'd probably call it a state hospital now, but a hospital by Colonial Williamsburg that has the equipment they used at that time. So whatever, mid-1700s. And there, besides all the manacles and those kinds of things, there's a cage that is like 2 feet high that somebody was in. It looked like an enlarged chicken crate. Yeah. And it would have been the only way to keep that person from hurting themselves or others, so that it aligned with what was necessary to manage the physical behavior which was occurring.
For sure.
Yeah.
And they were in iron cuffs or camisoles or things which their arms were captured inside the clothes with, because it was necessary to keep them from hurting themselves or someone else.
Yeah. Some other things, when they thought it was a demon or whatever, sometimes they would do, it was a little bit like the Salem witch trials, right, where you dunk people, you do things to try to get the demon out, those kind of things. And unfortunately, it just led to, people not being treated well. But I think the other pieces...
But they were intended well.
I think that's the other part. You and I would go, they were not treated well, and then there's another part you go, it was the best that they knew.
Yeah.
Well,
and I want to go back to this, and I realize we walk a very fine line in understanding demonic possession. Sure. And we're going to say we believe, based on the scripture and example, and living in a world where we wrestle against principalities and powers and things that we can't see, that these things are real. But that might be for a different conversation and discussion. What I'm interested in here, though, is it would be easier to keep a person in a cage if I believe that they were demon-possessed. Is that part of the shift in mental health awareness that humankind has taken? Do you follow my question, observation?
It's not unlike what happened with slavery. In order to keep people slaves, they had to not be fully human. Mm-hmm. That's mental gyrations that get us there, but it is necessary in order to manage your own sanity. So if you had a child or a husband or sibling, whatever it was, who was blatantly psychotic, harmful, not just, if people would just run up and down the streets and scream, they'd probably let him. Mm-hmm. But somebody who's breaking into houses or in danger of fire setting or harming someone, how would you, and you would have to come to grips with, they may not be fully human as we perceive that. And so these interventions can and need to be done. Yeah. There were no other answers.
Yeah.
And I think, Matt, what's really interesting today, the characterization that mental illness equals dangerous is not an accurate representation of it at all. It's come to that it was kind of danger over there. Then it started to be able to come to there is humanity here that we need to somehow care for. Now then there was a whole period of time where there were treatments being developed and things like that. Then what do you see? It's very, very interesting. Now, seeking out good mental health and mental health treatments and online care and things like that.
Is good stewardship.
Is like, hey, you're worth it. Go. Hey, why don't you see a counselor at such and such? And so we've seen a pivot to now that mental health care is both important, but also like, hey, this is available.
Yeah.
Go do it.
And revered. And so what I caught with all of that too, Ted, is the shift in the posture that the healthy community has had with the ill health or those that are struggling has been the difference. Ron, I'd like you to go back then, tell the story then, pick up in the 1800s or whatnot. What did that look like here in Central Illinois as this wave of understanding and then shifting of posture changed towards mental health?
So the pieces I know would indicate this was a national movement and probably international in first world countries. But one of the things I just found amusing when I read it, nobody would ever think it today, but when they started to develop state hospitals, so they were large places with thousands of people there, and the primary purpose or component of it was to rest. It was thought that if we could get these people removed from busyness or commotion and just take them to a place where they could rest. Now, that didn't work, but it does show that there was a beginning of compassion and that it was seen that there might be a cure or at least some resolution to those symptoms if we could figure out what it is to do. So if you think about that, it means they're now being seen as a person and a fully valued person, even if the interventions were mistaken.
Well, and the big shift there from the cage that you described earlier or the log cabin was protect me. That was the posture to now how do we care for this individual is a 180-degree difference.
It was huge.
And that's what launched.
Even back then when they still were in the cages and the pits and those things, one of the ones that I read, and I think it might have been the fellow who was in that pit, they talked about his feet being off, that his family said we could give him to or send him to whatever, the county or whether that's jail or poorhouse, whatever. Yeah. But we were concerned about how he would be cared for. So even at that point, there was compassion for this broken person at the level they didn't want to just send him someplace. But I think probably the majority were sent to prisons, poorhouses where if their behavior was within manageable, but if not, they were imprisoned in cells because it was the only way to contain that.
I do think that that's a really important thing to see that the role of prisons and mental health care inside jails and prisons, there's a large mental health component, and jails are huge providers of mental health care.
Sure.
For all different, from addiction to untreated, and the amount of trauma that's in there. So that's a different discussion also.
Yes.
But from old time up to now, you'll find the jail or the prison being a place that a lot of this was treated. Yeah.
I'm interested in these shifts. So you mentioned the state hospital, a shift away from protect ourselves to how do we help this individual with whatever level of success or failure. I mean, they were trying, right?
Well, there were successes in that they were managed. They weren't leaving people outdoors and freezing, and they weren't locked up. So it was interesting when Illinois, I think there might have been originally like 5 state hospitals or something like that, and there was another one needed, and the Peoria area decided to go for it. To try to get it here. And I don't think it was entirely because of need. I think there were probably some pieces of prestige or of wanting to be known as a place that cared. And it actually was a group of women who drove that.
Here in Peoria local.
Yeah, looking for to make it local, to have it here. And they were successful. It wasn't just women who did it, but they largely led that. I think this was 40 or 50 years before suffrage. Before women could vote, these women took hold and did that. And in the parade for the opening day of the Peoria State Hospital, the mayor and somebody were in the first car, and the second car was the women who were the leaders of that group. So there was the treatment of mental health corresponded in some ways with women gaining credibility and seen as having the ability, just the ability and the wherewithal to pull that off.
But the clarity of worldview, the clarity of view of human came with these women, right?
Right.
Here locally.
The other piece I think is really interesting locally is that, and I think it was Dr. Zeller, he had a different view of what should happen than what other state hospitals did.
Okay, so introduce Dr. Zeller a little bit. What era are we in here?
I think this would be early 1900s.
Okay.
I'm going to avoid dates, but somewhere between 1900 and 1910, but early.
But after these women?
He would have been in the same era.
Same era.
Right.
Okay.
And he believed that you shouldn't use cuffs, restraints, bars in the windows, and advocated strongly for that. And I actually think, I'm not sure I have the time right, I think he was off in the Philippines War or something and came back and they'd put bars over the windows, and he was very upset. He had ordered them all removed.
Okay.
And they were actually used to create a bear pen or used in a zoo that he created on grounds. So he very much advocated people should not be restrained unless absolutely necessary. And he would do things like if the police department called because somebody had escaped from Peoria State Hospital, was walking around town, people called the alarm because they could probably tell either by what they were wearing or maybe how they were acting. And he would purposely send a single female to retrieve them and bring them back on the streetcar.
So he was radical.
He was radical. There's more to it. But he wanted the public to see this person was not dangerous, that a woman could take care of them, and that they could ride in public and they didn't need security guards. So he actually developed a reputation which concerned the other state hospital administrators, and they reported him to Springfield about the poor practice which was happening in Peoria. And so, like today, a nursing home would get somebody from the Department of Public Health. I don't know who came then.
So here he was ahead of his time, but there was a lot of heartburn with that. Now, a lot of that was very intriguing. When you say, he had his own facility then, along with this? So we have a state hospital.
No, he was the director of the state hospital.
Oh, he was the director of the state hospital. I missed that.
Here in Peoria.
Okay.
Yeah. Which is why they called the state to come and check. So this, what we'd say surveyor state, I don't know what they were called then, came and observed and reported back that the people were doing well. And not only was he found in compliance, but they recommended that other state hospitals follow his lead.
Interesting.
Just a major change in thinking. And of course, there were restraints at the state hospital. It wasn't that they didn't exist, but they were used very sparingly. And they didn't have he didn't want bars on the windows because of what it looked like.
Yeah.
They called it the cottage model, which kind of blows my mind because it didn't look like a cottage.
But it looked like a cottage compared to the prison.
Well, it started, I think the other thing, and Ron will talk about this more, but it started to see people too as there were people who were living there that would have a room and those kind of things. But then they started saying, hey, let's give this person something to do. And that's a really important aspect of the shift away from a person is ill, dangerous, and then useless.
Yes.
Okay. And I think that's that, and they didn't really realize that as ill at the time, but something was wrong with them. They were dangerous, useless, and so we're going. Wait a minute, they have something. They're dealing with an illness. They need to be treated as a human being, and we need to figure out how best to engage them in a life
Ted,
of value.
They were rewriting the script.
Sure.
Oh, totally. No, it's it looks very archaic and sometimes even a bit cruel when we look back on. But from where they came from, so one of the things he advocated is people should be working. So, and I don't have the numbers in front of me. I could look for them, but I think they had a dairy herd. I think they had 140 cattle, and that's what the men did, cared for. Plus, I had hundreds of hogs that they would slaughter each year and fields that they did. So, and they started using what today we would call occupational therapists. So they were very gender-based. So women didn't milk the cows; the men milked the cows. But the women, they started in sewing programs and cleaning programs. And so they made the linens for the beds, made the clothes, made the aprons that the people working there would wear, and thoroughly enjoyed doing. When minimum wage was put in place, they didn't have the money to hire all those people, and you couldn't allow them to work because that would have been treating them unfairly. So all of the animal were dispensed with. There was no more farm operation.
It undercut that
And
vision.
the people were back to sitting around, and they couldn't sew. They couldn't be used for housekeeping. So it was a serious setback from this idea, which was a very positive one. Even today, even when we have clients, we would look for, is there some kind of work they can do? How can they be engaged in the community? How can they be part of something meaningful?
Yeah.
Totally. And he achieved that. I mean, that was a really frustrating change when that was taken away. But the point I wanted to make more is how much that was his way of thinking. It was what will help these people, not how do we maintain them, but what will be helpful to their healing.
Yeah. I think another thing that really impressed me, it was a number of years ago, Ron and I actually went there to the site, and there was a number of cemeteries on site. Go ahead, Ron. Tell a little bit about the cemeteries.
Well, you almost have to go there to understand part of it. So one of the things that stands out is many of these people were lost. They came there without names. They just were given numbers because they didn't have a name. Some family had taken them to a prison, and the prison maybe put them in the poorhouse. They couldn't. In the process, nobody claimed them. They didn't have identities.
So in the cemetery, that's what you see unmarked. They're numbers.
Yeah, and catalog. And some of the numbers are names that are known, but many are not, or they were given a name when they came there. And they weren't necessarily able to say their name, if they were psychotic enough. But that's how much
But even if given a name is powerful, powerful gesture.
Right.
And I think that's part of the thing, that many of them didn't have families and things that day, or they had families, but and so when they passed, I think one of the things that impressed me so is that Dr. Zeller made sure that each one had a funeral.
Yeah, I'd forgotten that. Right.
Yeah. And there's simple gravestones with sometimes simple names, sometimes not much, but there was also some kind of recognition that
life was honored.
Yeah, life was honored.
Even in the fact that they each had their own gravesite.
Yeah.
There was no mass gravesite.
Mass.
And it wasn't an unmarked gravesite.
No.
Everyone had a marker, even if the marker only had a number, and they kept catalogs.
Yeah.
So they knew where each person was buried and which number they were by. It speaks of humanity, a shift toward humanity.
But just put it juxtaposition to the cage, right? Where it's like we're going to hold this person until the threat is over, to now we have an eternal marking that a life was lived. It is worlds apart.
Yeah.
It even speaks to the spiritual piece of that. I mean, we as believers, most of us don't reverence a gravesite, but there is something meaningful about that. The dignity is believers in a church, as we give somebody a funeral and a cemetery and a marker at the cemetery, it means we intend to remember and acknowledge who they were. Mm-hmm. It's not spiritual in the sense of sin or salvation, but of just integrity of humanity.
Right.
And it was reflected in how they were treated.
Do we know what Dr. Zeller's faith was?
I don't know.
I don't know.
He certainly... Yeah, he certainly was endowed with a grace that understood.
Yeah. He was not a psychiatrist.
Okay.
He was just a regular physician who took a deep interest in the mental ill and really led the mental health field, but not because of his own personal training. Yeah. It was his own conviction or desire to reach out and care for those people. Yeah. Obviously, a very remarkable man.
Yeah.
No, that's really fascinating. And you partly answered this question. Where did the individuals come from? It sounds like the facility, it wasn't just the Peoria area. Is that true?
Do you know, I'm glad you asked. If you think about the area it was built in, so people didn't arrive in cars. They didn't come in ambulances. It was purposely built on a railroad because the only way to bring people in was by train. So it's still there. The tracks are still there. And if you go there, I'm pretty sure the stairs, they were when we went and looked, that go to the tops. And so the staff of the hospital would know there's a train coming with people, and they would come.
And so they would be coming from anywhere in the United States?
In-state.
In Illinois.
But
it was a leading
Illinois.
Facility in Illinois, so this would be a place you could go.
Yeah, and it was Dr. Zeller's intent was to have it open to everybody, but the funding piece of it controlled that most of the people had to come from a poor farm or a prison. Oh. And he was wanting it to be more open than that, so he would negotiate or find ways to admit people from home who needed to be there. So they would be told, I don't think they knew how many were coming, but that there were people coming. They'd go down to the cars, and some of them they just had thrown in straw, and the people were just laying on the straw. Not all of them were mobile. There's a story, and I can't quite picture how this worked, but a nurse thought she got a box of clothes and was carrying it, and it started to move. And there was a woman buried in these rags of clothes. I think they nicknamed her Betsy because she didn't have an identity. But it's just interesting to picture, it's intake day or whatever you would call that. Yeah. And they would go down and they didn't get records. They just got people clearly defined as such.
But I would like to just capture one concept. You talked about funding and how there was a limit. Okay, when it comes to the care needed, it required community care. And we know this, right, as a church. It requires community care. I can care for my children, but when there are complications, you require a larger community to care for this.
Exactly.
And so there would have to be winds of change in the way people thought about mental health if they were going to have a facility in this area that could care for it.
Sure. in this model, the state hospital became a residence, okay, that was very different. It's very different from today. If somebody is psychotic or is a danger to themselves and they need to go to Peoria to Carl Hospital today, they're going to spend a few days to a week or two there, but then they're not going to live there.
Well, I want to make a comment on that model. It was interesting when the Peoria State Hospital was first built. They pictured resident people, they would have said patients then, coming there temporarily for a few weeks. That never panned out because they had in their mind that they could take them out of these stressful circumstances and that would be the cure for the madness that they were experiencing. And of course it wasn't, because these were people with really severe permanent mental health problems, which eventually we learned to treat a different way. So it was not pictured that people would come and spend their life there. That was a major shift in what they had pictured would happen.
Right?
So over time, there was, some big shifts in the United States in terms of healthcare and mental health care. And during that, one of those periods of time, really they started doing a lot of closures of those kind of facilities.
Would have corresponded, I think, with the introduction of antipsychotic meds.
Yeah.
So that short-term treatment could be done. And that was a major reduction. That the move was from those state hospitals in Zeller to more community-based. Now, not the group homes. So this would have been like Timber Ridge, which still exists, but there were large homes like that. Not so much for mentally ill, but it was for mentally retarded. But it was a part of that same movement. So the 60s and 70s maybe was a time period where there was a major move into the community. So not just a place to be, but existed in a community where people lived.
So you add on to those a place, moving away from danger to purpose, as you mentioned, right, Ted? And then this idea of being a part of a community and having this.
So I think there's, if you will, a best word to think about it is that whole system was downsized.
Okay.
So the concept is to get, when people are at a severe state, they're here in a residential facility, but then you go back home, or you're in a more of a group home, or you go back to your house or whatever. And again, for some people, it was great. It's a good thing. It's a wonderful thing. And I think that one of the challenges is that, you talked about simplicity. What we also want is one size fits all in terms of this is how it's going to be treated, and this is going to be the outcome. And the fact is that just isn't how it goes. But what it started to do is to kind of differentiate care, okay, so that you have care in one place when something is severe, care in another place when it's mild, care in another place when it's moderate, care outside of facility, all these different things, which is different from what we have today, but similar to what we have today. Sure. And so you can start to see how that was, kind of arrived.
Well, the way you articulated that the profession is developing,
maturing
in terms of understanding how to best care for individuals.
Yeah, I want to pick up on that a little because I think it's a really key point. And one of the things which was different is when you were admitted, it started with an assessment. So you were seen by a doctor, you were seen by a nurse, you were seen by a physical therapist.
With uniquenesses, right? Yeah. That's what an assessment does.
And then that developed a care plan, similar to the way we would think today. That wasn't true in the state hospital. It was just, how do we maintain that person? And the care plans were intended toward discharge, which is also a different way of thinking. And then from the past, right. Yeah. Discharge was dependent on not just one factor, but it was dependent on an appropriate medication and compliance to the medication, a place to live, which then defined a support group also. So families could do that. They could provide a place to stay if the person stayed on their medication, except for those people that had disorders that weren't understood, people who were non-compliant, people who were, so I'll just use an example. If somebody was paranoid enough, they wouldn't trust their parents or the caregivers, and they would end up on the streets. So the homeless mentally ill were those without support systems, without submitted care, without compliance to medication, or who would not and could not trust the system. But there were many if you look at the numbers, and some of these I'm going to be off a little bit, there was a time there were multiple state hospitals in Illinois with 5,000 people apiece in them. I think they said Peoria at the highest was 2,800. We're talking about thousands of people. And if you compare that today, the majority of them are in safe, relatively productive places. Mm-hmm. So it was a huge advancement. It's like they're all out in the street.
Yeah.
But there were those.
So here's what I'm interested in. I'm interested in, and I want you to check what I'm learning here. I'm interested in the development into therapy, development into medication, and those types of things. And I want you to now trace my finger here. What we went is from a paradigm that was fearful, a paradigm that was trying to manage disaster or manage harm. And then there was a shift of seeing people for who they are. And so let's label that love. But that love brings us into facilities to try to care. And then as they did that, it pressed them into the best care, which was unique care in many ways. Mm-hmm. Therapy coming out of that, brain science coming out of that, I'm guessing. Is that fair enough?
All of the above.
Yeah.
So go into that, Ted, either therapy or meds.
Yeah,
Where's that?
So one of the things we're really tracing here is we're tracing kind of the history of dealing with what we would refer as severe or persistent mental illness for a lot of it. And so the concept, though, is that back at 1900, you've got Sigmund Freud also in Vienna, and he's doing therapy amongst the wealthy, okay?
Right.
So that's a different kind of a track, but that so early on you've got dream analysis and interpreting if you have a dream about a spider it means you don't like your mother, that kind of stuff.
All coming out of the Freud.
All coming out of Freudian stuff. Okay. The interesting thing is, as goofy as all that sounds, he also picked up on some things like he was the first to identify denial. Okay, which today we all go, oh well, everybody knows it's
common usage.
Common usage. But so that was going on, and that met a certain group of people's needs or helped or didn't, whatever. And then we came through a period of time where things went really reacted to that, went very behavioral, very reinforcement schedules and very kind of stark models of reinforcement and even punishment models.
Kind of you can train it out of them.
Yes, and things of that nature. But it was very, very stark. It was almost like the person was robotic. The mental mind over here was kind of symbolic and deep, dark stuff.
With Freud.
And then you get kind of the robotic kind of we can program this.
Is that where Pavlov's dogs?
Yeah, you bet.
I pulled that out. That's
Pavlov.
Been 25 years.
And so what you had is B.F. Skinner here. He was the big behaviorist. And then as it's coming along, then you had the cognitive revolution where people started to go, your thoughts really matter. That was Aaron Beck. And Beck's model started going, it was kind of like, hey, if you think this way, you're going to have this kind of outcome.
Play out in your behavior.
Yeah. And so the cognitive model occurred. So as that's kind of going along, one of the things that's also happening is the awareness that you can help people with depression, with anxiety, with grief. Okay, and so you start seeing opportunities to help people along the way. Not only were those schools of therapy emerging, not only these ways of dealing with the persistently mentally ill, but you also need to understand the impact of war. And the reason is because so many, we went through World War I, we went through World War II, we've got Korea, we've got Vietnam. So now we have to deal with another factor, and that's trauma and addiction. Okay? Mm-hmm. And that's a whole nother vein. It took till 1980 until post-traumatic stress disorder was put into the disorder manual. 1980, Matt, okay? And so that means that there's all these different rivers and tributaries coming along, but then as they do, it develops an awareness that both professionals are starting to understand, but also society's understanding. And then the other thing is family. It gives families and churches different options as well.
One way to make sense of it.
A way it makes sense,
You know,
for sure.
If you think we don't need to do that, I couldn't do it well, but if you track the church or the spiritual understanding all the way back to the 1800s to today, it's always been uneasy because much mental health behavior looks either non-consistent with a believer's life or looks demonic. And the question, and so that's where people would go, even till today, that piece of what is then?
Yeah.
What is somebody responsible or what aren't then? We don't need to go into the pieces of it, but it helps for people to understand how their son who was in Vietnam is acting this way. Having the context of PTSD means he's not just a terrible sinner. There's something else which is occurring. It's very helpful to have that.
And because of that, when you see that this son with PTSD who drinks, okay, and maybe drinks out of control, we're not going to minimize the fact that he has a drinking problem and that drinking to excess is sinful behavior, but it gives us a context to figure out what we need to do to help, and that goes back to understanding the individual, how the community helps, and things like that.
Okay, so let's just...
Can you do a quick play on that?
Yeah, please.
So, this is a bit of a segue, which we won't do it at this time, into the church, the Apostolic Christian Church, and that alcoholism, I think, was the first thing that they began to address and try to understand what it was and see it in a context. That was an opening that this wasn't all just sin-based, although it often resulted in sin, but that there was more to it. And that caught the attention of people who were dealing with alcoholics, both in church leadership. I think it was probably the first presentation to the elder body was on alcoholism.
Interesting. I think that's fascinating. I think we're going to just pull this to a close now. Obviously, we're not done with this conversation, and so we're going to continue it. You just tipped your hat, Ron, at our church, and I think we're very interested to know how our church has matured through all of this. But maybe if I can just bring some sort of summary, the impression that I'm left with is really the power of love. Isn't a power of love powerful in terms of bringing us from one understanding of a situation back in the 1700s and prior to where we're at now with care for people and providing them? It is just a stark difference. And love really kind of carried that journey in seeing people for the beauty God had bestowed upon them as image bearers. And so it has forced us to really ask hard questions and give over simplicity and to accept complexity. And a lot of good has come out of it in terms of even your profession, right? In a different way. So thank you both. We'll have another round of this. Thanks. And to our listeners, I hope this was helpful at some level in bringing some clarity to mental health. May is Mental Health Awareness. Thanks each one for being on.